Thank you very much. I love this meeting because I find it very stimulating, and I just had this great idea while you were describing this new monitor that to develop a monitor to estimate height, that is, measure the cardiac output and estimate the height of the patient. An idea. Okay, disclosures. I cooperate with the following companies. I show you my email. I will show my email at the end. Anyone who would like to get a copy of my lecture can send me an email, and I'll be happy to send him a copy, but please do it within the next 2 weeks. So, hemodynamic monitoring is essential for proper decision-making in critically ill and high-risk surgical patients. And yet, each and every hemodynamic variable that we measure has limitation and confounding factors, and the point that I want to make this evening is that we have to know the limitations of these parameters, and knowing them, these limitations, is as important as knowing their potential value. So I put a list of parameters that we are using in our clinical practice, and I start with clinical examination, blood pressure, heart rate, and urine output, the economy class parameters, and it seems that many people that are disillusioned with hemodynamic monitoring go back and are satisfied just by measuring these parameters when they take care of their patients. However, there are a lot of papers out there, many of them quite old, during the days that the PA catheter was introduced, that show that prediction of hemodynamics in critically ill patient by clinical evaluation and by conventional monitoring alone is inaccurate and unreliable. Here is a very recent paper, which is an analysis of patients with acute lung injury, and it says that there is a high probability that physical examination findings of ineffective circulation, that is a long capillary refill time, knee mottling, and cool extremities, are not useful for predicting low cardiac index or Scvo2. This is an older study showing that in high-risk, hemodynamically stable surgical patient, there were no differences in the mean blood pressure, heart rate, urine output, arterial oxygenation at any time between survivors and non-survivors, although non-survivors had higher lactate level. Obviously, adequate resuscitation cannot be based on normalization of vital signs. So we go one step further and we go to filling pressures. Now, this is a results of a survey among German cardiac anesthesiologists, and as you can see, when asked what are your monitoring options for management of fluid therapy, nearly 90% said that they guide therapy by the CVP. But here are some people, and including myself, that thinks that estimates of intravascular volume based on any given level of filling pressure do not reliably predict patient response to fluid therapy. And the consensus conference that was headed by Professor Antonelli said as well, we recommend that preload measurement alone not be used to predict fluid responsiveness. And this is based on the fact that when you take the results of many studies that looked at the predictive ability of filling pressure that is to predict the response of the cardiac output to fluid loading, you invariably in these ROC curves get a 45 degrees angle, meaning that their predictive ability is like flipping a coin. I'm sure that you're going to see this slide at least a couple more times during the session. This is coming from the group of Jean-Louis Thibault, and these are septic patients, and you can see the CVP and the wedge pressure values, the CVP and the wedge pressure values of patients that are responders with an R, that is that they increase their cardiac output in response to fluid, and the non-responders. And obviously you can see that they look about the same. And that is that CVP and wedge pressure cannot differentiate between responders and non-responders. But there is more dangerous information hiding in this slide. These are patients that are non-responders. That is, their cardiac output did not increase with fluids, and yet they had a low CVP. If you would give them fluids, you will get fluid overload. On the other hand, here are patients that have a high CVP, and yet they are responders. If you are not going to give them fluid just because they have a high CVP, you may get occult hypoperfusion. And this is probably, most of you saw this review by Merrick, a systematic review showing, as I showed you in these cartoons before, that indeed the CVP has no relationship to cardiac output or to changes in cardiac output, and therefore it should not be used to make clinical decisions regarding fluid management. Another catch, patients with intra-abdominal pressure. On the left-hand side, you can see that this is an experimental study in pigs that have intra-abdominal hypertension had a low cardiac output and a high CVP, a misleadingly high CVP, because on the right-hand side, you can see that when the preload is measured by global end-diastolic volume or intrathoracic blood volume, then indeed the pigs with intra-abdominal pressure with a low cardiac output were actually hypovolemic. And this is what led Cheatham to say that traditional CVP cannot be used to accurately direct resuscitation, and to do so places the patient at risk for under-resuscitation, etc. So if the filling pressures are unreliable, then maybe we should measure volumetric parameters of preload, like the global end-diastolic volume or the end-diastolic area by the echo. Indeed, the volumetric parameters of preload can differentiate between responders and non-responders. Recently, for example, in pancreatitis and in subarachnoid hemorrhage, the intrathoracic blood volume was shown to reflect the status of preload much better than the CVP. This is work that we have done in cardiac surgery patients, and when you look at all these parameters, the static preload parameters like the intrathoracic blood volume and the end-diastolic area, you see that their sensitivity and their specificity is really not very good, because any static preload parameter cannot, by definition, predict accurately the response to fluid loading. Let's say that we have the perfect preload parameter. In this patient, when we give him fluids, the cardiac output would go up. But in this patient, having exactly the same preload parameter, we give him fluid, and it would not. So, again, coming from the consensus conference, for the first time differentiated between preload and fluid responsiveness, which is a dynamic parameter that reflects the slope of the left ventricular function curve. And this leads us to the functional hemodynamic parameters like the systolic, the pulse pressure, and the stroke volume variation. And in patients who are on fully controlled mechanical ventilation, you can differentiate between a responder and a non-responder, and that is the basis for the functional hemodynamic parameters that we are going to hear about. And certainly, they are the most sensitive parameters for assessment of fluid responsiveness in mechanically ventilated patients. And if we compare all the functional hemodynamic parameters on the left-hand side, we can see how much more sensitive and specific they are compared to static preload parameters. But they also have limitations and confounding factors, and the main ones are that they do not work on patients with spontaneous ventilation, and they are dependent on the stimulus, that is, the tidal volume and the airway pressure. Coming to the cardiac output. Well, it's difficult to assess cardiac output clinically. We are good clinicians, but we are not that good. And this is work done years ago that show that blood flow, cardiac output cannot reliably be inferred from arterial pressure and heart rate. This is a multi-center study that was not published yet. It was 206 critically ill patients that were evaluated by 300 physicians, and you can see that the percent of accurate prediction of cardiac output was 35%. Only 35% of clinicians predicted cardiac output correctly. And by correctly, I mean plus minus 20% of the measured value. What is also interesting is more than 50% actually underestimated cardiac output at the bedside. So Jean-Louis asked, why should we measure cardiac output? And I come already with two responses. One is to identify patients that have low or high cardiac output values that are not evident clinically, and to assess response to diagnostic and therapeutic intervention. For me, the cardiac output is like a speedometer. I don't need to see a study of 10,000 cars with speedometers and 10,000 cars without speedometers to like the speedometer, use the speedometer, and feel that I drive more safely when I use a speedometer. But cardiac output in it by itself is not enough. This is a recent study, again, patients with subarachnoid hemorrhage, and you can see that early after their admission, they have a very high cardiac output. But look at the global end-diastolic volume. It's very low. They're hypovolemic. So at least in this subset of patients, a high cardiac output doesn't mean that everything is okay. Or let's take this one, just the same example that Jean-Louis gave. Here's a patient with a cardiac output of 7. It looks great, but is it adequate? The SCVO2 is 60. Obviously, this cardiac output is inadequate. Patient is getting dobutamine, and the cardiac output is going up, and the SCVO2 is going up. So cardiac output was high, but not high enough. So the limitations of cardiac output, the optimal cardiac output for an individual patient is difficult to assess. A low cardiac output doesn't tell you what to do. And a normal, even high cardiac output does not preclude the presence of inadequate regional or microcirculatory flow. SCVO2, everybody loves the SCVO2 because we all realize that the cardiac output is just the output of a sprinkler. But what is happening to the tissues, some of them don't look so well. So we are becoming maybe better in increasing oxygen delivery upstream, but I put this oxygen consumption extraction in a black box because indeed it is a black box for us. And we try to evaluate it by looking at downstream events, and this is why we look at the SVO2 or SCVO2. It is exactly for this. Everybody loves SCVO2. Andy Rhodes loves SVO2. Jean-Louis Vincent loves SCVO2. Michael Pinsky. Clearly, SCVO2 is a gold standard for defining global adequacy of cardiovascular performance. And indeed, we'll hear about that. In a perioperative period, the low SCVO2 is associated with a high percentage of complications. And that is true. But in sepsis, and this is where the SCVO2 got this tremendous exposure, actually in sepsis, the SCVO2 is mainly normal or even supranormal due to the reduced oxygen extraction. This is the problem in the high output septic shock, reduced oxygen extraction. And if we play with the Fick formula, we can see that oxygen extraction is 1 minus SVO2. So if the oxygen extraction is low, SVO2 must be high. And therefore, a normal or high SVO2 does not necessarily indicate adequate tissue oxygenation. And indeed, when we look at other studies, the SVO2 of patients in septic shock is high or normal, certainly higher than the 50% values that were found by Rivers. in this multi-center study, three ICUs in the Netherlands, you can see out of 125 patients septic shock, only 8 had SCVO2 less than 60, and only 1 less than 50. Now we're going to hear about this from Benoit Vallée. This is work for Fabrice Vallée. In ICU resuscitate patient, targeting only SCVO2 may not be sufficient to guide therapy, and he's talking about the gradient of the CO2. We'll hear about that tomorrow or the day after tomorrow. These are 44 septic patients, and those that have a red circle around them had a high lactate and a high SCVO2. The meaning of that comes clear when we compare them to Rivers' resuscitation groups. When you look, Rivers took all his patients, the control and the early goal-directed therapy, put them together in a later study, divided them into 3 resuscitation groups. It is obvious that he does not have, never had, patients that have high lactate and high SCVO2, but we do. And then, of course, there's the problem of the relationship between the SCVO2 and the SVO2. And indeed, when the SCVO2 is lower than the SVO2, this has a big significance. These are 2 studies, very good studies, showing indeed that this gradient is due to the reduction in oxygen extraction of the splanchnic circulation, most probably, and have a very bad prognostic value. So the problem with the SVO2, a low SVO2 tells you that something is wrong, but not what to do about it. And when oxygen extraction is reduced, as is frequently the case in septic patient, a normal high SVO2 doesn't guarantee that perfusion is adequate and that resuscitation is complete. I will not go through other parameters, but you see the drift. Each and every hemodynamic variable that we measure has limitations and confounding factors. And I also want to talk about protocols, because this is so relevant. We are under tremendous pressure to use protocols. And protocols use numbers of variables of these parameters that we measure. This is the president of the Society of Critical Care Medicine. And he is saying that medicine has become complex. Details have become overwhelming for clinicians to process at the bedside. We recognize the need to give up some measure of autonomy, yield some decision-making power. The data certainly suggests that when we surrender this autonomy and standardize care, patients do better. Well, this may be true when you look at ventilatory management, of weaning protocol, sedation, transfusion, but hemodynamics, we just heard how complex the hemodynamic world is. And if we look at those protocols that were suggested, hemodynamic protocol, this is by Society of Critical Care Medicine in 2004, and the resuscitation is based on the assumption that in most patients, septic shock cardiac output will be optimized at filling pressure between 12 and 15. I advise you to look at this reference 26. It's a paper from 1983 that includes about less than 30 patients in septic and hypovolemic shock. This is the basis. Or we just saw this protocol on SVO2. It starts with SVO2. But when SVO2 is more than 70, it says do nothing. But SVO2 more than 70 can exist in a patient who is in a severe septic shock. And secondly, using the wedge pressure to differentiate between hypovolemia and myocardial dysfunction, I think that the literature does not support that. And last but not least, the Surviving Sepsis campaign, a CVP of 8 to 12, again an SCVO2. So these protocols may be quite misleading. So I'm coming now to something that Jean-Louis already said. The application of invasive monitoring data is very complex. is not easily included in therapeutic protocol that are applicable across heterogeneous populations. Hemodynamic management is made complex because adequacy is not synonymous with normality and because correct application must integrate several variables. Reality may be more complex than initially thought. So the correct application of monitor cardiopulmonary and other variables is characterized by the large number of variables and how they interact, the importance of initial starting conditions to eventual outcome, the effects of unexpected events, and the nonlinear dynamics. Small things may have an enormous impact downstream. I have not made that list. I copied it from the principle of the complexity theory. These are the principle of the complexity theory that describe weather and traffic. And this is true for our patients. So whoever thinks that with a simplistic protocol we can take care of them is optimistic. The other thing, of course, is that the protocol is based on the assumption that every abnormal number should be normalized. And this is not necessarily true, certainly not in critical ill patients and patient and therapeutic conflicts, and I'll talk about that in the next couple of days. So what should we be doing? Because this nihilism that Jean-Louis Vincent warned us against is there, out there. People see all this information and say there's no point in monitoring anymore. So here are my 4 final comments. First of all, I want to reiterate, and this is why we're all here, that hemodynamic monitoring is essential for proper decision-making in critically ill patients, and the fact that this statement is not supported by evidence-based medicine tells us more about the shortcomings of evidence-based medicine than those of hemodynamic monitoring. The fact that each and every hemodynamic variable that we measure as limitation and confounding factors has to be recognized. It has to be incorporated in our thinking, in our practice, in how we teach. It's very difficult to come to young students and confuse them. It's so nicer to say, oh, CVP, 8, 12, etc. Or rather than they're in their formative years and say, well, we don't know, 8, 12, and they come out of the lecture like this. But this is the world. If you tell them that 8 is good, or that 8 to 12 is good, they are going to become bad doctors. Since no hemodynamic parameter is perfect, and I agree with you, a multi-parametric approach may reduce the chance of erroneous decisions. And attempts to protocolize care in critically ill patients have to leave room for clinical judgment, especially during therapeutic conflict like a heart-lung conflict. My last slide, I would like to quote a favorite book of mine. Many years ago, when I was in San Francisco, if you meet the Buddha on the road, kill him. We must live. It's so relevant, unbelievable. We must live within the ambiguity of partial freedom, partial power, partial knowledge. All important decisions must be made on the basis of insufficient data. Yet we are responsible for everything we do. No excuses will be accepted. Thank you very much.